Yeah, no problem. I can do that.
I'm just gonna have a quick look.
Hi, everyone.
Hello.
Hello. I was going to say dead silence. It looks quiet on me.
Morning. I guess
Morning.
because everybody's on mute.
Yeah.
Yeah.
It's like, what's going on?
Sorry.
Good
yeah,
morning.
good
Morning.
Morning.
Everybody's behaving today. Quiet.
It won't last.
Linda is with me. She's in the background.
Okay.
Morning, morning.
Morning. Oh, we'll just wait for a few more to join because we're all a little bit early.
Morning.
Morning. Morning.
Oh, sorry, just to let you know that Jane and Lynn are with me.
Hi, Jane. Hi, Lynn. For those of you that don't know me well enough yet, you know I like your cameras on, so if you wouldn't mind, please, those of you that got them switched off. We're just waiting for a few more to join because we're all still a few early birds. Okay. Just so today we're going to go over the governance report. It's nothing majorly exciting, but all I'm going to do is go over the organisational section. You'll read your RDs over your regional sections, and they will discuss those with you separately. Just wait for a few more. Morning, Sahir and Sally.
Hello.
Okay. Well, first, I just want to say congratulations to Hayley Gibbs and Linda Hatton on getting your nurse registration as managers and registrations for your home. So congratulations and well done. Welcome to nursing home care. They're all very quiet. I don't think Hayley's there actually.
She's just popped to the toilet. Sorry.
I see. Well, she missed it. I've got to say it again now. That's fine. Okay, so I'm going to share my screen because we've got a few pages to get through. So this report comes out every 4 months. We were a bit slow on it this time because this was the first time that we did it and we needed to get the format, etc., sorted out. So this report covers the 1st of June to the 30th of September. The next reporting period is the 1st of October until the 31st of January. So we will be once again undertaking our reviews of the stats, and we would hope to have the report out by kind of end of Feb, middle of March latest. It just takes a little while to finalise it, because actually what we also do is the draft report goes into our governance meeting with your RDs and we go through it and discuss it. And it might be that something comes up that we add to it. It might be that I go and check a fact, or the RDs will research something, etc. So we add that to there as well. It also covers health and safety, training, health and safety and training. Doesn't currently cover finance or marketing, at the moment it's just quality, training and health and safety. But it's still a bit of a whopper at 100+ pages, but I'm not going to bore you with all of that. So let's just start. So these are just contents pages. Purpose of the report obviously is to give Sam and Ozzy oversight of what's going on in the organisation and to evidence that we have that oversight if it's ever questioned. So, you know, if in your CQC inspections, if you're ever asked how is information escalated up to your chief operating officer and escalated back down again, your answer is kind of the governance process, the governance system, that there's a governance meeting and a governance report that is produced and that it's shared with you, etc. Okay, so that's how we feed up and feed down. This page is just talking about where we are, overdue events, etc. So it's mainly a daily reports and overdue reporting. So the themes that we found as an organisation around daily reporting is that obviously the unrealistic setting of timeframes for completion, and that was specifically around maintenance tasks. So sometimes when we put a maintenance event onto Radar, we set a time frame which we feel, you know, is what we want it done in, but actually it's not always realistic as into the time frame and the process that needs to go behind getting that piece of work done, because it may be that we need to get quotes and it may be that we need authorization for the level of spending that is required. So sometimes those timeframes are unrealistic, which means an action becomes overdue without actually even had time to go through the process it needs to go through. And what you would have noticed on your maintenance events is that everything now has a preset time frame, or will have a preset time frame. So we've put that into place, and that's been done in collaboration with the maintenance managers. So we've gone through and understood what a basic time frame is, for example, for repairing a tap or refitting a kitchenette or whatever it might be. And we've put set timeframes against all of those, and they've agreed those timeframes. So now when you put a job in as such, an automated timeframe should come up, which helps you also understand how long that job would take to complete. Sometimes the other thing that came up is, and I know I've talked to the PIA assessors about this, and I know we talked about this before we went to the PIA assessor approach, is putting multiple actions onto the one action point, which makes it really hard for you to manage, and it makes it really hard for us to see action. So each Radar point should have each action should have its own individual point, so that you can reassign it, so that you can change any time frames that you need to change on that point, etc. So that was across the company. One of the other things across the company was that the housekeeping actions were getting muddled in with the maintenance event actions, which meant that sometimes they just weren't getting actioned because the people that needed to see those events weren't seeing them. So we are pulling out the housekeeping, and they've got their own events log now, so that they will be able to see them. All these changes will be communicated within the project phase for all of those. And again, on the maintenance events, the issue was that sometimes where the issue was poor. So you might say tap was broken, but it didn't say in what room, what floor, etc. So it was just getting more detail in. I think we've resolved that in some of our project planning. And as I've already said, the events that required higher authorization. So there were our key kind of themes from that. Remembering that this is across the organisation, okay? So this is all of you. So it might be that there is a theme higher in one region and another, but overall, it flags up a lot. So the themes that kind of came from your mock inspections was you not reassigning tasks and letting your tasks build up and becoming overwhelming. I know we've talked about that a lot in these meetings about how to manage your tasks and stop that occurring. Not reviewing the actions on a weekly basis. So no, not evidencing that you've looked at actions. And I know we've talked about that a lot, so I'm not going to keep going over that. And reviewing the initial date, because, for example, when we do a mock inspection, we set 30 days. It's up to you then to review it as to what is achievable in that time frame. Because if I'm asking you to do something and you know you've got 4 nurses on leave and you're not going to be able to achieve that, then you're setting yourself up to fail straight away, and you need to review that time frame and make sure it's something that is plausible for you to use. When we were looking at Radar, one of the things that came up is, obviously we send all our lessons learned out via Radar. We send all our policies out via Radar. And it asks you to confirm that you've received them and read them. And people, as you can see, 78% of people that receive the notices aren't confirming that they've read them. So we need to improve that. And I know in the Radar webinars that it's gone through about how we do that. And I'm sure we sent something out in Daily News as well about how to do that. So it's remembering that if you get a lessons learned, if you get a policy update, you need to confirm that you've seen it, because it's our evidence as an organisation that that information has been sent out and received, and it's an important aspect of our governance process. So you know it's important that you do that, please. Weekly reviews. It's been hit and miss, but I know that's a standard that we've implemented when we implemented the new governance standard, so it's something we're still working on. Radar usage, everybody logged in most days, so that was 100%, so well done. I wasn't sure what that one was going to come out at, but it shows that everybody logged in every day. You know, you was all using the system. It wasn't anybody that was going, you know, 7 or 8 days without checking their Radar and checking what was on it. So well done there. Quality statement assessments. This is just a snap picture of where we were at the point in time. So this is up to September. So if you've had yours done since then, it's not there. What I will say, and I should have said this right at the beginning, is you will see some names, homes of names here. This isn't a name and shame. Okay, this is just about us saying where we are. So if you see your home up there and you think, oh, don't worry about it. Okay, the fact that we know where you are means that we can put support in to move you forward. So please see it from that viewpoint. Okay, there's no naming and shaming here. This is just about us being open and transparent about where we are as an organisation and our journey that we need to go on. So as you can see, we've managed to get 3 goods in the new process. We know that our mock inspection is probably a lot tighter and a lot harder than the CQC inspection will be, but at least then we know that when CQC come out, you're going to be in a good position. We are soon to start the second round of 6 monthlies. We've got a couple of homes left to do. I think we haven't done Swain, we haven't done Longfield, so there's a few of you buzzing around that are due soon. Not that I gave you a heads up, but you know, due soon. So then we just talk about the lesson. Sorry, does anybody have any questions on that section before I plough through? No? Okay. So then we just really cover the things that we've learned in that quarter. So this is kind of the policies and things that we've updated. So sometimes we update policies because there's been an organisational change in approach because of something that we've learned. We update policies because legislation has changed. And we update policies, we just do a review of policies to check where we are. So these are all the policies that have been reviewed and checked in the last quarter, and anything kind of that we've, a little brief of what we've done to them. Okay. But you would have received an update on all of these on your Radar, and it would have been in the daily news what policies have been updated. So you should know what these are, but just for a brief overview, they're there anyway, just so that kind of, you know, Ozzy and Sam know what's been done. These are all the lessons learned that we've sent out within that time period as well. So we just kind of put down how many that are there, kind of things that they covered. And next time around, we'll compare to the ones that we've put on this one to make sure that, you know, we haven't got a similar lessons learned, because if I've sent a lessons learned out once and we're sending it out again in the next quarter, that would say to me that we haven't learned the lesson or something's not right in the information that we sent. So we would need to review that. And that's another step next time, is that obviously we'll compare to this quarter's data, because this is the first set of data that we've pulled like this. So we don't have a comparison for it yet, but next time we will. And then we move on to group risks. And this just goes through kind of all of our different group risks. So these are our risks as they stand at the moment. And the things that, you know, I go on all the time about. So compliance with using the systems and setting our timelines, detailing our documentation, you know, covering ourselves. I think I had conversations this week about, you know, if you, even as team leaders, if you go and seek advice from your manager about how to manage a person's health or a medical decline, make sure you document it, because it evidences that you've sought you consulted, you've considered it, and the actions that you've taken. And it's remembering to document those conversations with families, you know, document those conversations with professionals that might seem ad hoc at the time, but later on down the line, if something then occurs, something happens, families become unhappy, it supports how you have communicated, information that you have shared and actions that you've taken. Because if we don't, you know, we don't know the journey each of our people in our care are going to take. We don't know what path they're going to end up going down, or whether family's going to be happy for the whole time that they're here, or if an incident will happen. You know, we can't control that. What we can control is making sure that we document. We're making sure that we put down that information and put a clear note of conversations and advice and support that's been given. Training and development, obviously we had a low compliance rate to start with because we changed the required of statutory and mandatory training was changed when I kind of first came into post, and that caused us to drop and then come back up again. But we're moving forward, and we did have some specific roles that had a lower level of competency. I won't drop your regional teams in it, wink wink, but they've resolved their issues now. Action management, overdue actions, which you know, I go on about that all of the time. Your RDs send you out emails about it all of the time. Incident and risk management has come up because sometimes we let ourselves down in our documentation in our incidents, and I know we've talked about that as well. You'll see a theme here, so everything that I'm talking about we'll have talked about at some point during these meetings, because I tend to discuss it with you as they come up. But it is really about putting, like we talked about last week, making sure we're putting clear timelines in of what's occurred in incidents, making sure we've got real good evidence of the actions and the investigations that we've done in those incidents, because they're the forms that we send through to the insurers when things go wrong. They're the forms that we send through to the coroners when things go wrong. You know, they're the forms that we rely on when things go wrong, or when people aren't happy with the outcome. So it might even be that it goes to the ombudsman to evidence actions that we've taken, you know. So these are the forms that we rely on. So it's important that we fill them in as comprehensively as we can with the information that we have in the point of time, because trying to remember information from an incident 6 months down the line isn't easy, because you'll have dealt with 15, 20, 25, 15 further instances since that point in time. Medication management, there were some issues with barcode scanning that kept coming up that caused a few errors and posed a few risks to health. It wasn't anything that the team members were actually doing per se. It was, I think it was, and Simona, you can correct me if I'm wrong, it was the fact that the barcodes were fading and weren't scanning properly, and that was causing some issues. Observational supervisions, obviously that was new, but it was some incomplete or undocumented supervisions of monitoring staff care and performance. We know that in looking at that, we need to improve where we were keeping them, because they were being kept at different places, and it was hard to kind of formulate what had and hadn't been done. We had some overdue ORM meetings and a little bit of documentation that needed improving on those, and management on radar. Care plans, not surprising, care plans being there. You know, we moved to a new system, so care plans and assessment management was always going to be on there. Accuracy of care plans, etc. And then another one, again, going back to that communication and documenting, was communication at handover was inconsistent and didn't always reflect what had been verbally handed over. So it was remembering, you know, reminding people to exchange key pieces of information. Are there any surprises there? Is anything, oh, I didn't expect to see that there for anybody? No? Okay. Any questions on that? No? Okay. And then we're just going to a few bar charts. So we had an issue with, we went to the new governance system, we've had an issue with the care plan audit that was in place. It was taking too long. We were having, so we've reduced it back down. It now takes 2 hours, but obviously that caused a risk, because we haven't necessarily audited as many care plans as we should have audited. And that's what this graph basically shows, the schedule against what we actually achieved. It just supports the fact that the form wasn't working. So we've reduced that down, and we won't see a decline in that next time, because the new form doesn't come out until February, but we should see a decline hopefully in the next round of that. Out of the quality statements, infection control has been one of the biggest kind of flags that has come up across the homes. And these are the key areas in which have been an issue. So the cleanliness of hoists and standing aids, bed pumpers still being on beds when they're soiled or split. You know, if you've got a bed bumper that's degrading, take it off. You know, no one's stopping you from reordering a new one. Please do so. Support handles soiled. So it's just kind of general cleaning and cleanliness. Shower chairs, remembering to look underneath them. As those of you that had inspections know that Amanda likes to lift up a toilet seat and a shower chair and check underneath it. It's one of her things, be warned. So, you know, it is making sure that we do that, because there's nothing saying inspector won't do that. So we need to make sure that we do. Malodors, management of malodors in some areas. Bin usage, bins not having lids on them, wrong coloured bags in wrong bins, you know, a black bin with a yellow bag in it, a yellow bag with a black bin in it. Remembering that there is a segregation process, you know, there is a colour coding in place. We should use it appropriately. Uniform policy not being adhered to. I did see something about that come out in the Daily News lately about uniform policy, but jury wearing was quite high on that. So remembering, you know, infection control is jewellery wearing. We're not supposed to wear rings if we're delivering care. We're not supposed to have long nails and nail polish on. These are all infection control risks. So think about that. Armchairs split and soiled. So armchairs that, you know, had splits in them, again, infection control risk. Infection control and audit nurse will tell you, harbouring of germs, etc. And it's just getting your teams to remember, if a drink is spilt, to lift up the cushion and clean underneath. It's not just the top. Michelle, you got a question? No?
Hi. No, sorry,
Hi.
it's me, Linda.
Linda,
Hi.
you got a question?
Just a quick question about uniform and jewellery and everything. Yesterday, I said to a carer she should take, you know, like the rubber band bracelets, and she said it was a religious one from her church.
What does it represent?
A Catholic faith.
Faith, yeah.
I don't know that we would recognise that. It's definitely an OSA question.
Yeah, that's what I said. We was like, oh, I said no, take it off.
Yeah, I would agree. I mean, a cross on a necklace that's underneath and not visible. The problem is it's washing hands and infection control.
Yeah.
She could still wear it somewhere else. She could put it on a chain, wear it under a long chain under a uniform. You're not saying she can't wear it. What you're saying is she can't wear it on her wrist.
Yeah.
She could wear it on her ankle.
Yeah, well, that's a good idea. Okay, yeah.
Yeah, so I would go back with that one. We're not saying she can't wear it. What we're saying is she can't wear it on her wrist because of infection control.
Brilliant. Okay, thank you.
Yeah. Yes, remember lifting up your armchairs. And then again, it's just about management of equipment, you know, soiled mattresses, split mattresses, maybe having a conversation in your team meetings, reminding team members if they see equipment that's split, you know, to report it so that you can replace it. These were the health and safety risks. I know we had some stuff around RIDDOR beginning of the year, which has come up around what we do and what we don't report. And I know we've discussed that quite a lot, so I'm not going to go into detail about it, but we had a few here or there. And that just covers those. Fire evacuations, we've started putting those onto the LMS in that quarter because we realised that we couldn't evidence that everybody was doing 2 a year, which is our requirement under our policy. So that was changed. Another one we've talked about a lot is duty of candour. And this just gives you a little brief overview of kinds of things that are coming up and being reported, and kind of how many each home are doing. I expect to see an improvement in that next time because I know that we've had lots of conversations about what should and shouldn't be reported, etc. Linda?
So just a quick question. Duty of candour. So if we've had a fracture, done the first letter, and then it's been stopped at alert by social services, do we do the second duty of candour letter?
Not until your safeguarding's closed and you've got an outcome.
Yeah, so it's been, so I've done the first.
Oh, okay, so
closed.
the safeguarding's closed with an outcome?
Yeah.
Or just a quality alert, not a...
No, it's an alert from social services. They closed it at alert. There's no concern. So do I do Doc 2.
Yeah, so now you can do a letter saying that the investigation's concluded and what you found. So it was an accident, what measures you put into place, etc. Yeah.
Lovely. Okay.
You've raised
thank
it for safeguarding, no concerns have been filed. So it's just a letter covering the outcome of the investigation. Okay, sorry. Any other questions on that? Like I say, I do expect to see an improvement in that because I know we've had lots of discussions around it. And my point of view on it is, if you're not sure, send the letter because it doesn't do any harm. You know, we're not going to get penalised for over reporting. We're being transparent and honest. So if I'm concerned, send it. If I'm sure, send it. Risk and insurance claims and coroners, we've just done a little bit of a comparison year on year. So you can see what kind of things, whether there's any kind of increase or change. Potential claims have gone, although it looks like they've gone up when you count the numbers, they haven't really gone up. And coroners are about the same. However, I have seen since the medical examiner came into being in September, I don't know about the RDs, but I've seen quite a few more of the query going to coroner than were before. So it'll be interesting to see what that looks like next quarter. But it's just to kind of give you an idea of sorts of things and how much involvement we have from KEOGS in those areas. And KEOGS is our KEOGS, for those of you who have been involved, is our solicitor that we use, our preferred solicitor that we use for coroner's court or for anything very complex. We only use the insurers for kind of non-complex stuff and for items that the insurers believe that they're just going to settle on because actually it costs a lot to not settle. If you can hear my dog barking, I'm really sorry. Weight loss. So actually I was pleasantly surprised at weight loss because we don't have a huge amount of weight loss across the organisation. I've seen higher in different organisations, so well done everybody. There is 251 people with a high must, indicating a score above 3, as you know. Thing that we need to work on, and we've got a food group to do, is we're working on how we fortify, where we fortify, and kind of just improving some of that stuff and how we do that. But we've got a food group that I think a couple of the managers here are on, and one of the RDs is on. So we're working through how we do that as a region, improving our offerings and snacks and all those other kind of things. Supervisions and appraisals and levers. So these are levers by regions. I haven't got any kind of detail on this part about behind, but just so you can see in each region, you know, how the movement really more than anything else. Remembering that London and Milton Keynes are slightly smaller, but if you put them together, yeah, because there's 5 homes in each of those compared to kind of 11 and 10. These are levers by roles. And as you can see, carers is the highest, but it is also, you know, the highest volume of employees as well. So you would expect that, with nurses kind of coming behind, and catering team actually, and housekeeping. Levers by tenure, so levers by length of service. Most people are between the 1 to 4 years, which in some ways, you know, people tend to move on more after 2 years, especially in care. They want change of experience, especially care team members. If, you know, if they're not interested in progressing, sometimes moving to a different organisation is the change that they need. But as you can see, this is where we sit with that. And then reasons for leaving, and just a little bit more detail. In the main, resignations, and then a few dismissals, but a small percentage really. And these are the things that we've done in the last 4 months or so to kind of mitigate the risks that we talked about on the first page. So all of the new things that we've put in, so the webinars, these, you know, topics of the day. So on your daily news, when we talk about a different topic every day, the bi-weekly radars, the weekly care plans for specific homes, the Nourish workshop. I don't need to go through them all, you can read them. But these are all the things that, you know, that we've new controls that we put into place in the last 4 months. And then on the right hand side, you've got the existing controls that are in place. And then slips, trips and falls. So this is just an overview of the flips, trips and falls for the organisation as a whole. 9 to 12 on a Wednesday, apparently, in a bedroom. Don't ask me why, but that's where and when. You can see. Oh, so that's overall. We have had some kind of peaks coming from July to September. I don't know whether our importing's improved. It may well be that's the case. I'm not sure. We'll keep monitoring it and see.
I just want to add something. So
yep.
They for this year they will keep grow because more homes have been added to Norwich system.
Sorry.
So
thank you. I knew there was a reason.
From Norwich.
What was the reason for that? I knew that it was. I probably wrote it in here. Actually.
So we had it was. It gradually keep add up. So hopefully this report that is going to come out in February probably will be the same, but after that it should settle a little bit because then we'll have all the homes in this one system. So. Yeah.
So I had actually written that in the first paragraph. If I read my own paragraph, I could have told you that was the reason. And obviously these are the homes that are on Nourish, 9 to 12 on a Wednesday in a bedroom. Okay. Reportable and witnessed. Most common location remains to be the bedrooms. We are looking at that. We're looking at acoustic monitoring, all sorts of other stuff that we could possibly do to support that. So that is something, we've got a full strategy that will be coming out, etc. So we are looking at how we can reduce that down. Again, remember these stats, different sized homes as well. You know, an Allywell bar chart compared to a Abbott's that's got a lot more beds is going to have more on it. Okay, so please bear that in mind when you look at these stats. And this is Cambridge region. So again, it still remains bedrooms. We did do some investigation into why Primrose and was so high, didn't we, Jane? When it first came out, we looked at that. And then this is Milton Keynes. The data is a little bit different because Milton Keynes is on the radar system still. So the other system was on Nourish. So that's why it looks a little bit different than the other one did. Did I miss Essex? No, Essex is there. Sorry, there's Essex. There's Cambridge. So if you read the little, I'm not going to read it all out for you, but if you read the little blurb at the top, you can see kind of what we've said about the homes. But it's just giving you an idea of the data that we can pull now. And that's Milton Keynes. So then we looked at skin integrity and wounds. So we looked at kind of the 2 homes with the notably highest percentage of wounds and issues with their skin integrity. This could be down to a variety of reasons. Okay, this could be because they're reporting better than other people. This could be because, I don't know, they've had more issues or they've had a moving and handling issue. There's lots of different variations that could go in there, but we kind of looking at what they are. And I've tried to compare them to, if you read the blurb, you can see that we've tried to compare them to homes of similar sizes to see if there is a differential there as well. But obviously this is something skin integrity wise we would want to reduce down, especially the contusions and the skin tears. You know, they're ones that we can reduce down. Pressure injury again, moisture lesions. These are all things that we can try and manage and reduce down by looking at our practices and what we're doing and how we're doing it. So that was Essex. This is Cambridge. And again, there's a little comparison for Cambridge about which homes and comparison against each other, looking at the average per person, etc. And then London and Milton Keynes. And then group training. So this is one of the things that we found in doing this was that we had a lot of external training that was being booked, which obviously we pay per head on the external training. But then we found that the attendance at the external training was very poor. So we were paying for lots of places that we are not using. So that's a huge amount of cash that we're spending on training that we're then not actually providing because there's no one, because we've got poor attendance, or we've had to cancel the training at short notice because we don't have enough people to run the training. So that is something that we're definitely looking at and reviewing, how we therefore then use external trainers, how we book them, how frequently we use them, etc. And that's it really. As I said, there is down then one for each region that breaks it down even more. Okay, but your RDs will share that with you because we'd be here forever if I did all 100 and something pages that there are. Can't remember how many pages there are on it, but there's a lot. Any questions? Do you think any of that information will be useful to you? Silence. I've stunned you all.
Yeah,
No one
definitely.
I think they will be once they can digest it and then see next, and then see the next periods as well.
Oh, you've got
I mean,
echoes
I
there.
certainly think it will be, and I certainly think the comparisons are good to be able to see because you know, gives you something to aim for, if you like. You think a bit of competition there, isn't there? Really, you know,
If you want
look
it,
at
there
you,
is.
you look at it and you
Yeah.
think, oh dear,
But yeah,
I don't like that. I better
at
up
the
my
end of the
game.
day, I think we need to remember that the aim at the end of the day is to improve the standard of care and to improve the experience of people in our care. If we make it fun by doing a little competition, then fine. But the aim is to make the person's experience and quality of life when they're with us a better experience and better quality of life. Simona.
Just checking, about a year ago when I was going on my email, I was able to then click on the Radar link to take me to Radar. I'm assuming that one has been taken off because I don't have access. It's not me personally.
When you say
but
on your email on Radar link, do you mean inside an email itself, or?
Yes. So when I go on the email,
The
there
Daily
is
News one?
Yeah, and when you click on Radar, it doesn't. When you go, I'm just thinking about the Radar notifications that you're asking about, because there's, you said 78% they haven't had.
Okay, so those notifications, you need to go on your dashboard.
Yeah, but if you click that link, it will take you to Radar.
Okay.
But if you're doing it from home, it's not going to allow you to do that because you're not in the. Okay.
You're not in the VPN. So because of the one sign in, because you don't have to sign into every system, the one sign in, you have to be on the VPN to be able to sign in. So if you were at home and you had your laptop and you were looking to go on to Nourish, for example, unless your VPN is engaged, you won't be able to get on it.
That's fine. I understand for my own laptop, but for access for the carers, if they have their own emails to access for e-learning and whatever, if they've got access to Radar, they're more likely to read the Radar notification from home rather than at work.
Yeah, it's
I don't know if there is other ways.
Yeah, I know. It's something that we've talked about a lot at some point. It may be that we end up giving everybody some kind of device that they use, but we can't put a VPN on everybody's phone at the moment. You know, there's lots of complications there. So from a management viewpoint, and I was only looking at managers, okay, I didn't look, sorry, I should have been clear on that. When I looked at who'd looked at Radar and signed off notifications, it was about looking at managers.
Oh, okay. I thought it would be the.
No, it wasn't everybody.
Oh, okay.
No. it was the leadership teams. So yeah, it's the leadership teams that we were looking at. It wasn't everybody. The policy sign off and how they've looked at those, we are looking at that because at the moment, Radar doesn't do it the way we want to do it. We're hoping to get that onto the LMS at some point, but obviously we're dealing with other things on the LMS at the moment, trying to get it all set up and sorted. But the idea is in the long term that policy sign off, acknowledging that we've seen policies, that we've read policies, will be on the LMS. Each training will be linked to a policy as well. So if they undertake, for example, skin integrity training, they'd have to then tick to confirm that they read the policies that were linked to that piece of training. So we'd have that piece of evidence as well that they'd read certain policies. So policies has been an issue, I think, since I joined, and I know it's something that we need to evidence better, but it's just finding the right platform to do it. Anka, oh, you've been quiet.
Sorry,
I was waiting for your
just
question. Oh, you froze.
To warn are going to try and compare themselves with other homes, as I've run a very small home who probably at one point had the largest number of falls in the company, and I was being questioned daily why. just remember your own circumstances and your own residence, and not always comparing to other homes is the right thing to improve standards in your own home. So just wanted to leave that there, because in my 30-bedded home at one point we were having 50 falls a month, and everybody was up in the arms. So just remember that.
You're right, Inka. Arc fest going on behind me. I do apologise. Hold on 2 seconds. Sorry, somebody dared walk past the front door, I think. What was I going to say? It does change, and it changes as your people in your care home change. You know, at some points you probably have more people that are at risk of falls than other times that you do. So there is always that variability in there. And that's why I said don't compare yourself to other people, because there are other comparables in there that affect it, you know. Because what I didn't put in there was how many of those falls were attributed to one person, you know, because sometimes a home has a high level of falls, but actually when we look at that, and I think that was the case at Primrose, when we look at the data, it's usually attributed to one person. If there is a high level, it can quite often be attributed to one person that we're managing and dealing with and trying to work out why they're falling. And sometimes it takes a little while to rectify that. Leslie?
Oh,
or
Marianne.
one of
No,
you
it's just I think it just allows you to see the wood for the tree sometimes. When you see it in that sort of format, it allows you to focus and kind of refocus your lens to where you need to be looking. You know, why is that home got those high? Let's dig into a little deeper. It could be absolutely fine. Everything's in place, but it allows
makes you ask the question. Just makes you ask the question, and that's what it's about. It's just us being open and transparent and making us ask the question of, oh, well, why? That's a smaller home. Why has it got a higher volume? Let me look at that. You know, because when you're looking at the data on its own for the home, it doesn't necessarily flag in your head. It's when you look at it side by side that it flags. We're only doing this once every 4 months because there's a lot of work in there, you know. So, and actually you need a decent time period to be able to, no worries, Jackie, to be able to kind of compare data from whether actually the actions that we then put on from the last time we did it, have they had an effect? Because if we do it too quick, we won't see that. One of the comparisons that we've done in the regional ones is we've looked at, and your regional team will share it with you, but we've looked at kind of your first PIA reports compared to your next PIA reports, and can we see any improvements? And that's quite interesting, because there is quite often there was an improvement in most of them from the first time that you had your audit round to the second time that you had your audit round. So that was really good to see. Obviously, the regions that have been on the new auditing process for longer have more data. So there's more analysis on Cambridge's than there is, for example, on Essex, which was the last one to come over, because we didn't really have 2 months to compare. We didn't have actually 2 months to compare for you in that period. So we looked at instead how many kind of audits have been completed, what your average percentage score was, and things along those lines. So for example, Essex won't have that on this report, but you'll have it next time, because you know you've had your PIAs in. Was it October you started, Marianne? I can't remember now. It was October, wasn't it? Yeah, I thought it was. So you know you'll have that data this time around. As I've said, I don't know whether this will develop and add extra bits and bobs on it, or whether it'll get smaller and the stuff Sam doesn't want on it. So, you know, it will evolve and it will change as we evolve and change. And if it's something that you found useful in me sharing with you, you know, your RDs are sharing it with you, but we can always do the group one in here when it comes out. I don't mind doing that. It's not a problem if it's something that you'd like, because it's quite nice actually to see what the other regions are doing and make you feel like, oh, okay, we're all in the same pathway, which I know that your RDs will tell you that anyway, but it's nice to visually see it, isn't it? So, okay. Any questions, any queries? You're all very quiet today. Any questions or queries or anything that you want to go through? No? Have I got any updates for you? Camiscope is still moving forward. We've got a meeting coming up, which I'll invite Celia, Jane to discuss kind of implementation. We're still, the contract queries have all gone back to Camiscope and they're now sitting with their lawyers. We just got to wait for that to come back. So once that's all kind of done and dusted, then we'll have a date to start. So that will go forward. What else is going on? The road shows are going forward with being planned. We've got a presentation to finalise content on that. Oh no, it's been moved back, isn't it? We will have a presentation to finalise content on that coming up, but they're due to start in February time. So so you'll go back to seeing everybody from support office at least once a year on that. Simona, you had a question?
The medication platform, how is it going?
That's Camiscope, sorry, that's Camiscope. So the extension on the Atlas contract runs out in May. So we're on quite a tight time frame for the trial. Which is why obviously you were asked, Milton Keynes Homes and Cambridge Homes were asked for their medication cycle dates this week, so we can start looking at go live dates, etc. Even though we haven't got the contract signed off, we still need to start kind of thinking timeframes that we want to go through. You'll have seen invites come out this week, or you've been asked by your RDs this week for nominations for certain working groups. That would be the environmental sustainability group, for the risk assessment group. So in the next couple of months, they're all going to be starting up to move forward on those journeys. What else is going on? Feels like there's so much going on at the moment that I can't actually wrap my head around it. Inspections, as I said last time, have started back up. I don't think that audits or new audits, I've said, will come out in February. I think we're going to try the radar webinars monthly, because we didn't get much attendance at the bi-weeklies. Attendance was a bit poor. And although I know last time you all told me that, yeah, you need a little bit more, and I did pass it on to Alvin, by the way, so he's going to organise in those monthly webinars to cover those topics that we talked about last week. So they'll be available for you. Was there any other topics that you feel that we are missing, that we haven't covered, that you think would be useful? Because obviously we've done the nurse training, and I will look at team leader training once that program's up and running. We'll look at a team leader program. We've got the managers program that's also in development. Is there anything else that you think, do you know what, it'd be really helpful if we had? I'm not saying that we can necessarily do it, but it's interesting to know what else you think we might be missing. Lynn, what have you got?
Can I just ask, I've got a team leader coming back from maternity leave that did the upskill training. Will she be allowed to do insulin and PEG things?
I can't remember what was in the upskill. Is that insulin in the upskill training? Remind me.
The insulin, yeah, I can't remember if they did PEG or not.
How long has she been on maternity leave for?
6 months.
And did she do the training just before she went? Or did she do it during her maternity leave?
No, she did it before she'd gone, but she's a trained nurse in her own country.
I would say, if she's done it, I would say let's do a set of competencies with her, just to make sure she's retained the information.
Yeah,
okay. Do a set of competencies with her around the areas that she did on the upskill.
Yeah.
Put them on her file, yeah. And do a supervision just to discuss it with her and cover it that way.
Wonderful, thank you.
Simona?
Sorry, just the last one.
No, I promise. I don't mind you asking questions.
I don't know how everybody with access on Nourish through their phones, but it's my personal experience. When I receive, when I'm on call and when I receive an email saying that there is an incident, an accident or something happened during the night or something, I personally panic and I'm like, what's happened on my on-call time and da-da-da. So what I have to do is get up, eat early, morning, night, whatever, and I have to go on my computer to go on Nourish and da-da-da. Is there a way of the people who are on call to have access to Nourish when they are like basically having VPN? So I've asked IT and they're saying it's VPN on their phones. So is there, I mean, I don't know if anybody else finds it difficult, but it's just my thought.
Anybody else have that issue or worry about that? I mean, I would say you shouldn't be getting up in the middle of the night, Simona, to check an incident on Nourish. You know,
No,
you
but
need to
it's
trust
just-
your team to
Yeah,
phone
well,
you if it's
yeah.
not something they can manage.
Okay.
Yeah, so that would be my first response to that.
Okay.
Yeah, and then check it in the morning. I get checking it in the morning, but Sally, maybe you need to have a conversation with her about
It's just
sleeping
because
through
if,
the night.
if you are on call and you are somewhere, you are available, but
Yeah.
I don't obviously take my laptop with me
laptop with you.
everywhere.
No, I
So
know.
yeah, that's my only, yeah.
No, I know. It's something, as I said, VPNs on phones is something we've been discussing for a while, mainly with the maintenance managers, because they're on their phones going around all of the time. They don't carry their laptops with them. Same as you, but for radar, as in if something emergency comes through and it's on radar and they want to see it, they can't see it. So it is conversations that we're having, but I'm not in charge of IT. So it's not really in my hands, but I will pass on the comment around VPNs and mobiles and on-call for a discussion point, something that we need to consider in the future. If you've got if you haven't allocated a work phone, then I'm not sure that it's an issue. If you're using your personal phone, I don't know. So they're the things
No,
that I
it's-
can't, there's lots of little
I've
caveats
got
there.
allocated, yes.
You've got
Allocated one.
you've got an
yes.
allocated one.
Yeah.
Okay, that's fine. I will find out the question. It might be something simple, but I know it was a little bit more complex because it also depends on what phone you've got, whether you've got an Apple or whether you've got an Android, because it's different VPN apparently, which is makes life even more confusing. But yeah, that's as much as I know about that one, Simona. Sorry. Any other questions? Anything anybody's stuck with? We've got Simona, so if there's any Nourish questions, now's the time. Simona's sitting there. If there's anything you're struggling with on
Well,
Nourish.
I jumped every time when you said Simona, I jumped. I was like, what do I have to say? So every time when you say Simona, so Simona, keep your pen down. What I just want to add something. We have some troubles with the training on Atlas, which you're all aware. So is that third-party platform that is directing the people to log in. So when you have a new nurse, a new starter to do Atlas and you prompt them to do training, I think that for the time being, they will just have to do the medication training in our e-learning platform and then to go through the competencies and observations. In the meanwhile, until we sort out the situation with the trainings, because I'm getting calls from the nurses. I'm a new nurse. I was asked to contact you to get access. I can't give access to PCS. So until we sort out what's happening, I think for the system is just to go through the e-learning that they do on Kaleidoscope.
Kaleidoscope.
I was with Kamascope, Kaleidoscope.
Yeah, I didn't think about
the
that.
names are too close to each other. And then to go through the observation and the competency until we sort out what's happening.
Yeah. So the long-term plan, obviously, if we move to Camiscope long-term plan, then the issue with Atlas is resolved. The issue with Atlas is, as I've said to you before, is that they were bought out by PCS. So now to log on to do the Atlas training, you have to log on to PCS, which obviously doesn't go through our one sign-in system, etc., etc. And there's lots of issues around that. So we're just looking at putting a video onto Kaleidoscope with some questions at the end of it that talks through how the software in itself works, and then completing the actual medication administration training and awareness that is on Kaleidoscope in itself, not the one linked to Atlas, because actually when we've compared the two, they're exactly the same. So that we're not losing anything there. So that's what we're in the progress of doing. But as you know, we've also been doing lots of other things with the LMS. We've been sorting out the safeguarding training. We've been sorting out lots of other things that kind of just in the process of going from one system to another system that works slightly different. We've had to work out different ways to do small aspects of things and get them kind of reporting the way we need them to report. Okay, but we are getting there. Our stats aren't looking that bad at all, I don't think. And congratulations to all the regions that have managed now to get everybody logged on. Well done. I think that's Cambridge now and Milton Keynes. I'm not sure how London's doing. I don't know if Celia's, she might be on my other page. Oh, how's London doing, Celia? Are you here?
Something people, haven't we? 160
Don't know that she's here, actually.
He's got 300 and something.
Some of the managers, there's a care home meeting somewhere here
Oh,
in
okay.
Milton Keynes. So I think some
on that.
managers from Milton Keynes
Oh, that's
are
fine.
at that.
So I think Essex.
We've got about
Still-
100 so that still need to log on out of that 900 staff, 900-ish.
960 staff, haven't we?
Getting there.
Yeah, 960 staff, so 100 odd
But some are
still.
not logging on, some are leavers and all of that.
So that includes the mat leave on there, yeah.
No, mat leaves
Okay.
and some.
And you got the guidance on that, didn't you, yesterday, Leslie? I think it came through, or there was something come through on
Yeah,
that yesterday.
it's on my list to do this week, so I'll get that sorted this week.
Yeah. Okay, so that'll pop your steps up. So as an organisation, we're currently sitting at 86% statutory, 81% mandatory. So we're nearly getting there. Nearly. Something's happened there because they've all gone red again. So I need to look at that. I'll talk to I had some greens on there before. Now everybody's back to reds and ambers. I'm going to speak to Ali and Terry and find out why everyone's jumped back.
And you added more training, Wendy.
No, I haven't.
Yeah, there wasn't. I think there's a new one dropped in. React to dementia.
Yeah, it was added yesterday.
Oh, okay.
It was
I'll
added
talk to them about
yesterday.
Okay. Well, but it should. Okay, I'll talk to them because there should be a window on that if it's new for you to do it, and it shouldn't be making you. It shouldn't be making your stats drop. I'll sort that one out. Thank you. React to dementia. Okay. I'll find out what's going on there. All right. Anything else?
Just to add to that, I think the trainers are doing quite a lot of mapping because there's, you know, the React to Red and the different ones that are sort of slightly different themes, but they're covered in other training. So I think there's quite a lot of mapping going on, which hopefully will then get the stats back up. Yeah.
Yeah. So until we've gone, everything's done, you may still see your stats wobble a little bit here or there while we're just kind of mapping everything across. Really, there's still bits and bobs that are mapping. Leslie?
I was Marianne. I just
Marianne,
remembered
sorry.
I've got a lady that just started this week who used Hippo previously, so all the training. So with that, is there some way to easily transfer it, or?
Oh yeah, she just needs to same process as before, provide the evidence, and we can sign it off on the training that's been done.
That's good.
Lovely.
Because we recognise that easily. So anybody that comes into an organisation that's got certificates that are valid, as long as we can verify the training and that the training is to the standard that we require, then we can put the certificate on the system. We don't insist that everybody has to do everything all over again. Sally?
Let me put it down. Hello.
Hello.
Could I just have Wendy and Jane left on at the end, if that's all right? Because I just want to ask you something. Yeah.
Yeah, of course.
Thank you.
Of course you can. And Gina, I need to give you a Teams call in a little. Oh, she's gone. Where'd she go? Gina, I need to give you a Teams call in a little bit as well. Linda.
Yeah, I, as you know, do the assessments, and one of the things I see that hasn't come over yet is the falls prevention. They're going to call that reactive falls. So we're getting non-applicable at the moment. So
I don't know that it's I don't know that we've necessarily put reactive falls as a statutory or mandatory, which is why it will be a non-applicable at the minute, but I'll have a look.
Yeah, I think I spoke to Terry because I kept getting non-applicable, and the question in the assessment is about the training. So she said it is going over reactive falls, but just so you're aware that that's a little bit skewy on the assessments at the moment.
No, that's fine. That's fine. Just stick it on our chat.
Yeah, I've emailed Terry and she got
no,
back
I
to
mean,
me.
but just so that
on the PA chat, yeah, I'll stick it on the
PIA chat, because then obviously the inspectors are in that as well, so they'll see that and know when they go into the homes, etc. So yeah, stick it on the PIA chat, and then we'll all see it. Okay. The there was a question last week. Who was it? Was it you, Anchor? Yes, I think it was, about pending periods on radar. So Steve's going to do a radar session with the PISS about the pending periods. What we're doing is we're going to extend the pending period to 14 days. Okay, Anchor. So it should show on the dashboard when you reassign it to your nurses 14 days before the due date. Okay, so we're doing that.
Thank you very
change.
much.
That's all right. What has to happens is when the PISSs put the action on, they have to set it to 14 days. So they're just being shown how to do that, and then we'll get that sorted. Leslie or Marianne, I don't know which one of you it is.
It's Leslie this time. When we're talking about that training session, obviously the regional admins are doing the finance audit. So could we be included in that, please?
Yeah.
Because I'm a bit in the dark with this pending period thing because I didn't get any training on the new system. So yeah, brilliant. Thank you.
Okay. Any other questions from anybody? No? Okay. Right, well, everybody have a good day. And next week we will be talking about, so next week we're going to be talking about topic of the month, which is a new, is it a campaign? Maybe a campaign that we're bringing out. And each month there will be a different topic. So we're just going to talk to you about how we're doing that, any support materials that will be coming out with that, what we want you to do at home level with it, etc. Okay, so that's what we'll be talking about next week. All right. Okay, see you all later. Bye.
Thank you. Bye.
Thank you.
Bye.
You just check the end.
Let me just stop the recording because you don't want that on there, do you? Hold on. There we go. Okay.